Hi, my name is Yujing Steenwijk. I'm a PGY1 Health System Pharmacy Administration and Leadership Resident at Cone Health, and I will be presenting News You Can Use Pharmacy Updates from April 2021. I will discuss new hypertension screening recommendations and the X-waiver exemption for buprenorphine. Then, I will introduce two new FDA approvals, Qelbree for ADHD and Gemtesa for overactive bladder. Next, I will discuss updates from Cone Health P&T meetings, including penicillin allergy delabeling, SGLT2 inhibitors, and melatonin. Finally, I will review literature on the use of fluoroquinolones in aortic disease. First, let's review guideline updates. The U.S. Preventative Services Task Force released a reaffirmation recommendation statement on screening for hypertension in adults on April 27, 2021. The USPSTF first released a recommendation on hypertension screening in 2015. After commissioning a systematic review to evaluate the benefits and harms of screening for hypertension in adults, the accuracy of office blood pressure measurement for initial screening, and the accuracy of various confirmatory blood pressure measurement methods, the USPSTF concludes with high certainty that screening for hypertension in adults has substantial net benefit. This recommendation is consistent with the 2015 recommendation. The USPSTF continues to recommend screening for hypertension in adults 18 years or older, first with an office blood pressure measurement, then confirming with either ambulatory blood pressure monitoring or home blood pressure monitoring before starting treatment. This is a grade A recommendation. As far as the interval screening, there is limited evidence, but the USPSTF suggests that it's reasonable to screen adults age 40 or older with increased risk annually. Screening can be less frequent in adults younger than 40 and not at an increased risk, and with a prior normal blood pressure reading in the office. Next, let's talk about the X-waiver for prescribing buprenorphine. The X-waiver is a federal certification requirement for physicians and other clinicians who want to provide medication-assisted treatment, or MAT, for opioid use disorder. Providers with the X-waiver has a DEA number that begins with the letter X. This month, the U.S. Department of Health and Human Services, or HHS, released the practice guidelines for the administration of buprenorphine for treating opioid use disorder, which exempts eligible physicians, physician assistants, nurse practitioners, and others from the X-waiver to treat up to 30 patients with the drug. The exemption applies only to the prescription of Schedules 3, 4, and 5 drugs or combinations of such drugs, such as buprenorphine. Therefore, it does not apply to the prescribing, dispensing, or the use of Schedule 2 medications such as methadone for the treatment of opioid use disorder. This regulation change represents the removal of a long-standing barrier to physician prescribing of a medication-assisted treatment. It's important to note that before treating patients with buprenorphine for opioid use disorder, practitioners must obtain a waiver by submitting a notice of intent to the HHS's Substance Abuse and Mental Health Services Administration under established protocols. The next topic is new FDA drug approvals. Qelbree, or viloxazine, is a new non-controlled, non-stimulant ADHD treatment for pediatric patients approved on April 2, 2021. This is a serotonergic and noradrenergic modulating agent and is available as an extended-release capsule. The initial dose in 6 to 11-year-olds is 100 mg once daily, and it can be titrated in 100 mg increments weekly, up to 400 mg daily. The initial dose in 12 to 17-year-olds is 200 mg once daily, and it can be titrated in 200 mg increment in a week to a max of 400 mg daily. There is a boxed warning for suicidal thoughts and behavior, and it is contraindicated in concomitant MAOI use or concomitant CYP1A2 substrates with a narrow therapeutic range. The most common adverse effects are somnolence, decreased appetite, fatigue, nausea, and vomiting. When compared to Strattera or atomoxetine, an SNRI used for ADHD treatment in children and adults. Advantages for viloxazine include no hepatotoxicity, faster symptoms improvement, and fewer drug interactions. In addition, Qelbree capsules can be opened and sprinkled onto applesauce for ease of administration in younger patients. This medication will become available in the second quarter of 2021, and cost will be competitive with other ADHD medications on the market. Gemtesa, or Vibegron, a medication approved for the treatment of overactive bladder in December of 2020, is now available on the market. This is a beta-3 adrenergic receptor agonist with a fixed dose of 75 mg once daily as an oral tablet. The most important adverse effect to watch out for is urinary retention, and it does not have any hypertensive effects. In comparison to Myrbetriq or Mirabegron, the only other beta-3 adrenergic agonist on the market, Vibegron does not have a warning for angioedema or blood pressure effects. It has fewer drug interactions, and it does not require titration. Next, we'll discuss formulary updates from the April 2021 Cone Health P&T meetings. Over the last 12 months, you may have noticed the infectious disease team working on penicillin allergy assessment and testing. The PGY2 infectious disease pharmacy resident has been leading this effort with the goal of delabeling patients without a true penicillin allergy and increasing first-line antibiotic use. He presented the results from this project at the April P&T meeting. Of the 48 patients included in the study, 47 or 98% had their penicillin allergy removed. Only one patient developed a delayed rash and was relabeled with a penicillin allergy. No patient had an anaphylactic reaction to the amoxicillin oral challenge, the penicillin skin test, or direct IV therapy with a penicillin product. Once the allergy was removed, these patients were able to use preferred first-line antibiotic 70% of the time. When compared to a retrospective cohort who did not undergo penicillin allergy testing, the delabeled patients had significantly lower 30-day readmission rate and lower rates of acute kidney injury. The study reinforced the importance of critically evaluating a penicillin allergy before defaulting to an alternative agent, and the infectious disease team will continue the effort of delabeling patients to optimize antibiotic use and patient outcomes. Next, we'll take a look at SGLT2 inhibitors. There are 4 agents in the class: Invokana or canagliflozin, Jardiance or empagliflozin, Farxiga or dapagliflozin, and Stilotro or ertugliflozin. Currently, canagliflozin is the only SGLT2 inhibitor on formulary at Cone Health. Since this class was last reviewed at P&T in 2016, empagliflozin and dapagliflozin have been studied in heart failure patients with or without diabetes. The EMPA-REG and EMPEROR-Reduce trials with empagliflozin demonstrated benefit in reducing hospitalization for heart failure, but not cardiovascular death. The DAPA-HF trial with dapagliflozin demonstrated reduction in both hospitalization and cardiovascular death, and subsequently received FDA approval for a new heart failure indication. Because of these new data, it was recommended and approved to add both Jardiance and Farxiga to the formulary. Next, we'll look at melatonin. Melatonin has data for regulating circadian rhythms and promoting sleep. It is becoming a common dietary supplement in the outpatient setting. However, the FDA does not approve dietary supplements. With non-formulary orders for melatonin continuing to increase in our hospitals, it was recommended that melatonin be added to the formulary, and it was approved in January this year. To assure product quality, only USP-verified melatonin supplements will be stocked in the pharmacy. Now, the 3 mg and 5 mg melatonin tablets can be ordered on Epic as a formulary medication. Lastly, we'll do a literature update. Fluoroquinolones is a class of broad-spectrum antibiotics that has been associated with a long list of warnings. In 2008, the FDA added a box warning for increased risk of tendinitis and tendon rupture. In 2011, a box warning was added for worsening myasthenia gravis. In 2013, A warning was added for increased risk for peripheral neuropathy. Then in 2018, 2 new warnings were added. First, a warning for hypoglycemia and neuropsychiatric changes in the elderly, and then a second warning for increased risk of aortic rupture and tears. If fluoroquinolones increase the risk of aortic rupture, what's its effect in patients who already have aortic disease? An article by Chen et al. Published in the Journal of American College of Cardiology this month sought to examine this question. This was a retrospective cohort study with over 30,000 Taiwanese adults who survived after being admitted to the hospital for aortic dissection or aortic aneurysm from 2001 to 2013. The authors assessed the patient's fluoroquinolone exposure every 2 months, and amoxicillin was used as a negative control exposure. The authors found that fluoroquinolone use was associated with a higher risk of all-cause mortality, aortic-related death, and later aortic surgery and stents in patients with aortic disease. The findings of this study reaffirmed that fluoroquinolones should be a last-line option for antibiotic treatment. In summary, we reviewed the new hypertension screening recommendations from USPSTF as well as the X-waiver exemption. We looked at new drugs such as Qelbree for ADHD, as well as Gemtesa for overactive bladder. We looked at 3 formulary updates, including penicillin allergy delabeling, SGLT2 inhibitors, and melatonin. And lastly, we reviewed evidence for the risks of fluoroquinolone use in aortic disease. Here are the references for this presentation. This concludes News You Can Use Pharmacy Updates from April 2021. Thank you for watching.